New webinar. So my name is Dr. Binali Usama. I'm a general practitioner and I practice in Morocco. So today we will be talking about endodontic obturation. Let's go ahead. So the contents of these presentations are going to be the objectives of the obturation, some criteria and conditions, the obturation materials, and finally we will be talking about obturation techniques. So let's start with the objectives of obturation. What is a root canal obturation? What do we mean when we talk about an obturation? It is a three-dimensional filling of the root canal system after the chemomechanical cleaning and shaping and the disinfection. This is a quote by Herbert Schilder on 1967. He defined an obturation as the sealing of a complex. He mentioned complex because not always a root canal is going to be a round, straight canal. It's going to contain isthmuses, lateral canals, and delta branching. So it is the sealing of complex root canal system from the periodontal ligaments and bone. This sealing is the one that's going to ensure the health of the attachment apparatus, meaning the periodontal ligament and bone, against the breakdown and destruction of endodontic origin. So let's focus here on this word right here. It's a three-dimensional filling. So an obturation, an endodontic obturation is not always judged by a 2D radiograph because a 2D radiograph is only going to give us information about either the canal is underfilled or overfilled, but not always the sealing level of this obturation. The root canal obturation is going to prevent, first of all, the prevention of ingress. It's going to prevent the ingress or the entry of the microorganisms back into the root canal system after the disinfection. It's going to prevent the multiplication of the microorganisms, the one that remained inside the root canal, inside the dentinal tubules, after the disinfection, because the disinfection is not a sterilization. When we disinfect and we irrigate using disinfectants, we do not sterilize the canal. Some numbers of microorganisms remain inside the root canal system after this process. It's going to prevent the leaking of apical tissue fluid back inside the canal through the apex. And of course, it's going to prevent the bacterial reinfection of the canal from the periodontal pockets or from the gingival sulcus or the gingival fluids. So what are the criteria and the conditions that we can have, that we must have in order to obtain a well and good obturation? What are the conditions that are necessary to exist in order for us to go ahead and obturate a root canal system? We can obturate a root canal space only when there's certain conditions. Among these certain conditions are absence of pain and symptoms. And we will talk in detail about each condition right here. When there are no symptoms such as tenderness to percussion or a positive percussion, of course. When there is a healing of a sinus tract or either a complete healing or a healing in process of a sinus tract. When we have a dry canal, we cannot obturate a canal that's still leaking either transudate or exudate or pus or whatever. When we have an odor-free canal. And of course, we can obturate in the same appointment when we have a vital case. And of course, finally, when we have enough time to complete the procedure. So let's talk about patient symptoms. And in addition to this point right here, we'll talk about vital versus necrotic cases. If the patient, for example, presents with an irreversible pulpitis case, this is a vital case. But the patient obviously is symptomatic. The only thing here, the symptoms are related to the existence of the inflamed pulp. Once we remove the inflamed pulp tissue, the patient will be no longer symptomatic. Therefore, we can actually obturate in the same appointment. However, if the patient presents with the severe symptoms of an asymptomatic apical periodontitis or an acute abscess, instrumentation will not resolve these symptoms. Therefore, obturation is contraindicated. In cases, for example, when there is a necrotic case, a necrotic root canal space is filled with biofilm, and the canal disinfection using only instrumentation and irrigation protocols will not be sufficient to remove this biofilm. And an additional intracanal medicaments such as calcium hydroxide is needed to obtain a full disinfection of the canal. Therefore, obturation in the same appointment in necrotic cases is also contraindicated. So this is a scanning electron micrograph study was done by Saad Al-Nazhan and his on 2014. This is a scanning electron microscope of a vital case. You can see the canal. This is a dentinal tubules. There are no bacteria here. You can see clearly the collagen fibers right here, and some pulp cells and pulp tissue right here. On the other hand, this is a necrotic case, and you can see the biofilm composed of multiple species such as Candida albicans and Enterococcus faecalis, the most responsible species for endodontic failure. So removal of all this biofilm using instrumentation and irrigation is not always sufficient, and we need to use other means of disinfections. So obturation, endodontic obturation, should only be carried out in these situations. Should not be carried out in these situations. First of all, apical periodontitis, as we mentioned, is especially symptomatic when there is an excessive exudate, when there is a purulent discharge, when there is a root canal retreatment. Even though the patient is asymptomatic, we cannot obturate in the same appointment during a root canal retreatment. And of course, during complex treatment such as a perforation repair. First, we repair the perforation, and we can obturate in another appointment, of course. So the third part of this presentation, we will talk about the obturation material. The gold standards, of course, of the material used during an endodontic obturation are two parts. The first part is the core, which is mainly gutta percha cones or gutta percha injected thermoplasticized gutta percha. And the second part is a sealer. So let's talk about the gutta percha. Gutta percha basically is composed of a gutta percha plant, which is a natural rubber occurring. It's a matrix. For the filler, they add zinc oxide, and for the radio opacity, they add some metal sulfate, such as strontium sulfate or barium sulfate. And finally, resin or waxes are added to add maneuverability and plasticity so we can handle the gutta percha well inside the canal and outside the canal. Some of the advantages of this material are the plasticity. It is easy to manage and manipulate. It's easy to remove in case when we need to do retreatments, and it's an inert material. I just want to point out that gutta percha is not a biocompatible. There's a big difference between inert material and biocompatible material. Inert material simply will not corrode, will not disintegrate, but can cause irritation and can cause inflammation. However, a biocompatible will most likely not cause any irritation, and it will promote healing and promote the healing process of either bone and other type of physiological tissues. Amongst the disadvantages of gutta percha, we'll talk about the lack of adhesion to dentin. A warmed gutta percha, when it's cooling, it shrinks. And finally, the poor sealing without a sealer. Therefore, gutta percha should never be used without a sealer. Some forms of innovative gutta percha, of course, are available in the market. Let's list some of these examples. There is a nanodiamond coated gutta percha. Basically, they add some nanodiamond particles with amoxicillin. So basically, it's an antibiotic coated gutta percha, which is going to help kill a lot of types of bacteria such as Staphylococcus aureus and other type of bacteria. And the second part, we'll talk about the bioceramic coated GP. Just coating the gutta percha cone with bioceramic is going to enhance the adhesion between the sealer, especially when a bioceramic sealer is used, between the sealer and this gutta percha coated bioceramic coated gutta percha. So let's talk now about the sealers. What is the function of a sealer? The sealer basically is used to obliterate the irregularities and voids between the root canal filling material and the canal wall, because since the gutta percha is a solid object, it cannot go and penetrate irregular or the deformations in the canal system. This is the job done by the sealer. Also, it improves the seal of the root canal filling. So the requirements of an ideal sealer, this is an ideal sealer we are talking about. So far, there isn't a sealer that can tick all these conditions, but some of them do better than others. Easily introduced in the root canal system. The second part is a sealing ability laterally and apically. The absence or even low shrinkage of the sealer after the setting. It should be impervious to moisture, so moisture cannot basically affect it. Bactericidal or at least bacteriostatic, which means either it's going to kill bacteria or it's going to inhibit the reproduction of the bacteria. It should be radiopaque. It should cause no staining of the tooth. It should be biocompatible, and it should be easily removed in case we need to do a retreatment. Most famous types of sealer used nowadays are zinc oxide eugenol based sealer, calcium hydroxide based sealer, epoxy resin sealer or simply resin sealers, glass ionomer based sealer, and bioceramic sealers. Let's take a look at this graph for a second. On the left side, there is we'll talk about the expansion of the sealers, and on the right side we'll talk about the shrinkage of the sealer. Most of the sealers are going to be affected by a shrinkage after the setting, which is a major drawback for most sealers. The exception of the bioceramic sealers, the only sealer that's going to exhibit an expansion rather than a shrinkage, which is the major quality of these bioceramic sealers. So when a sealer is shrinking inside the root canal space, it's going to leave a gap. It's going to leave voids, either between the dentin and the sealer or between the sealer and the gutta percha, which is going to be a good place for the bacteria to invade and to cause an unsuccessful treatment. The most shrinkage was noted in the calcium hydroxide based sealer and the zinc oxide based sealers. So let's talk about individual sealers. Zinc oxide eugenol based sealers. Amongst its advantages basically is the absorption if extruded past the apex. It is well absorbed by the periapical tissues. It has an anti-inflammatory and antimicrobial effects. This is due to the existence of zinc and the properties of eugenol. Amongst its disadvantages, first of all, is the transition into weak pore state after the setting, the shrinkage upon the settings, and one thing we didn't mention here in this presentation, which is the existence of eugenol inside is going to inhibit any form of restoration or a luting agent, or even like an agent that is based on resin, because eugenol inhibits resin polymerization. So, for example, if a fiber post is planted in a canal, and this fiber post is going to be cemented using a resin adhesive system, zinc oxide eugenol sealers are best to be avoided. This is a scanning electron micrograph of a zinc oxide eugenol based obturation. As you can see, after the setting, the sealer left a gap due to the shrinkage between the sealer and the dentin. And this gap can be a potential place to harbor bacteria. Calcium hydroxide based sealers. Advantages: antimicrobial properties due to the high pH. It has a milder toxicity compared to other type of sealers, and of course it promotes tissue healing. This is the reason why it is was widely used as a pulpotomy filling material, or even a dressing, intracanal dressing material. Amongst its disadvantages, the solubility. It disintegrates with time. So after a while, the only thing that's going to be left inside the canal is the carapace, and all the sealer is going to be washed away. So for the calcium hydroxide, the same thing can be said as the zinc oxide eugenol. It's going to leave a gap between the sealer and the dentin, or between the sealer and the carapace. Glass ionomer-based cements are rarely used nowadays due to the fact that basically it has an excellent adherence. It bonds to dentin, chemically bonds to dentin. It has an increased resistance to root fracture, basically because the root is going to be bonded. It has an enhanced resistance to solubility in tissue fluids, so basically it resists the humidity inside, and of course some antimicrobial properties due to the sustained fluoride release. Amongst the drawbacks are that basically it's technically difficult to prepare deep aspects of the root canal in case, for example, we need to do either a fiber post cementation, and of course it's difficult to remove in case of endodontic retreatment. In most cases of removal of this type of sealer is going to lead to iatrogenic accidents, such as perforations and transportations. Resin-based sealers, they improve the adherence, enhance tolerability of apical tissues, but the problem is it's technically difficult to prepare deep aspects. The same thing can be said as the glass ionomer, because it bonds to the dentin, and it's difficult to remove in cases of retreatments. It is potentially allergic and mutagenic to certain individuals, and of course the problem with the shrinkage upon setting. So the best, personally I think the best type of sealer is a bioceramic sealers. The disadvantage is, first of all, it's biocompatible. The ability to promote biomineralization and osteoconductive. It is an osteoconductive tissue. It enhances. It has an enhanced bonding between dentin and core material, and of course, it is dimensionally stable upon setting. Not only it does not shrink, but also expands. So if there is any void left during the obturation, after the obturation, due to this expansion, the void is going to be removed. The drawbacks, of course, is it's expensive, it's technically difficult to remove the canal for the retreatments, and of course, shorter shelf life compared to other sealers. So let's talk about, before we move on, these scanning electron micrograph shows two types of sealers: Cerasil by Mera Biomed, and of course by Root. And these, look at the adhesion between the dentin and the sealer right here, and the same thing can be said no gap whatsoever. And this is the reason why it's extremely beneficial and advantageous to use bioceramic sealers. So most common failures causes related to obturations are apical seal, coronal seal, lateral seal, either the canal is overfilled or underfilled, and of course the vertical root fracture that can be sometimes caused by some types of techniques of obturation, such as cold lateral condensation. And finally, let's talk about these techniques. The main techniques today we will be talking about are the cold lateral condensation, the warm vertical condensation, and the single cone hydraulic condensation. When speaking about the cold lateral condensation, there are some steps we need to take. First of all, the cone fitting. Cone fitting, we will be fitting a cone, the master gutta-percha cone, that's going to match the master file size, the last file used to finish the apical area, of course. So, for example, if we used a 30 size 30 file, the master gutta-percha cone is going to be a 30 size cone. Apical tugback is important in this technique. And I said apical and not just a false tugback. Accessory cones are used, of course, and a spreader instrument is used to condense the gutta-percha both laterally and apically. An obturation is done using one master cone and sometimes 4 to 5 accessory cones. And I've seen a lot of people do one master cone and 10 accessory cones, which is just going to complicate the process. And basically it just shows that inadequate accessory cone size has been selected. So this figure is going to give us a presentation of this technique. First of all, this is the instrumented canal and ready to obturate canal. We will try the spreader and see if it reaches the apex. First, the master cone is placed, and then the spreader is inserted while exerting forces laterally and apically. And in this type of forces that can sometimes cause vertical root fractures. So an accessory cone has been placed after that, and a spreader then is pressed both laterally and apically, creating space for more accessory cones. And when finally there is no more space left in the canal, the group of the cones can be seared off at the level of the CEG for anterior teeth or at the level of the orifice for posterior teeth. So this is another presentation. As you can see, this is the master cone, the plugger, the spreader, I apologize, the spreader to create space, and then the the first accessory cone, once again the spreader to create space, another cone, the spreader, and then another cone. And this is another form of. So as you can see, this is the master point, cement here, and of course the accessory points all over the place. I didn't mention that we need to put sealer, but it is the first thing you need to do before doing all these things. So once the canal is ready to obturate and you try the spreader, after this you need to put the sealer inside the canal, either using spiral lentulo or using the gutta-percha cone or the paper point cone. And then you can carry out with the process of obturation. So warm vertical condensation. This technique basically has two major advantages. The first is the ability to excellently 3D seal all irregularities such as isthmuses, lateral canals, and apical delta branching. And the second advantage is the ability to handle deep splits of canals and internal resorption defects. The technique has three phases: the cone fit phase, the downpack phase, and the backfill phase. The cone fit Before we start this process of the warm vertical condensation, we need to try out some pluggers, and to make sure the pluggers are going to reach 6 to 5 millimeters from working length. So once we fit the cone, the master apical cone, and the apical tag back is felt, the coating of the canal with the sealer using a GP, with using the gutta percha, or either the gutta percha cone or the file. And just one note here, all types of sealers can be used with technique except the bioceramic sealer, because the bioceramic sealers cannot tolerate heat, and this technique is heat dependent technique. So once the GP cone is seated and cut at the level of the canal orifice and packed using cold pluggers. So the second part, basically, we are going to use a heat source such as system B, for example. So a plugger from the heat source system is going to be plunged through the cone that we just placed inside the canal, all the way to 5 millimeters short of the working length. So 10 seconds is given to the GP to cool down while maintaining apical pressure. Why this maintaining of the apical pressure? Because as we mentioned before, gutta percha, when it cools down, it shrinks. Therefore, maintaining apical pressure is going to avoid and prevent the formation of that gap. After this 10 seconds, the instrument of the heat source is going to be cold. So a short burst of heat is given so that this heat source instrument is going to disintegrate and pluck off the remaining coronal gutta percha while retracted. And then a cold plugger is used to compact the remaining apical segment of the GP. And finally, the backfill using a thermo softened or thermoplasticized GP in segments. So this thermal softened GP is going to be injected in the coronal portion, which is empty, and is going to be compacted after each segment is injected inside the canal using a cold plugger all the way to the orifice level. So this is another presentation here. As you can see, the cone fit here. The heat source is plunged all the way to 5-6 millimeters short of working length. 10 minutes is left to cool down, and then short burst of 1 second, and then retraction of the heat source instrument. So this is the remaining apical portion has been compacted using a cold plugger. So next, this is the backfill. So thermal softened gutta percha is injected inside the canal, and then it is compacted after each segment is injected, all the way to the orifice level. And finally, we're going to talk about the single cone hydraulic condensations. This technique was invented by Dr. Ali Al-Naseh and his associates. It is a sealer-based obturation technique. So basically, we are relying on the sealer rather than the core, which is the gutta percha. Since we are relying on the sealer, we need the sealer to have excellent properties and dimensional stabilities. Therefore, we can only use bioceramic sealers when using this single cone hydraulic condensation. So using strictly bioceramic sealer, as there is no shrinkage and there is an expansion. The single cone performs as a carrier and a compactor to the sealer, hence the hydraulic condensation. And the size of the GP cone can either match the size of the final finishing file or a smaller size. For example, if we use the instrumentation file, the final instrumentation file is as 30, we can either use a 30 size cone or a 25 size cone. Why size smaller? So that the excess sealer can flow from a coronal direction rather than an apical one. So basically, we are going to irrigate the canal, and then we are going to dry, not completely, because moisture enhances the set of bioceramic sealers. Bioceramic sealers are the only sealers that benefit from a small existence of moisture. And then a tapered gutta percha cone is fitted to working length. After the fit is confirmed, retraction of this gutta percha cone, and then the bioceramic sealer is either injected directly in the coronal portion, and the injection directly into the coronal portion is only recommended in case when there is good illumination and magnification. You use in either loops or microscope, because you need to see how much you are injecting into the coronal portion only. And then, or you can use gutta percha cone or a paper point to apply the sealer, the bioceramic sealer inside the canal. So the pre-selected gutta percha cone is buttered with sealer as well, and then slowly introduced into the canal all the way to the working length, retracted, and then seated once again to create that hydraulic pressure on the sealer to cover all irregularities of the canal. It is not advisable to use heat near orifice level or near the sealer to remove the GP, as it desiccates the bioceramic, as we mentioned before. So my technique to remove to sear off the gutta percha is basically remove it using heat source at the level of the pulp chamber. But when I get closer to the orifice level, I only remove it using a high-speed burr or a slow-speed burr at 40,000 RPM. So first of all, this is another presentation of the single cone hydraulic condensation. The cone is fitted. This bioceramic is injected in the coronal portion only. The gutta percha is inserted inside the canal, and finally it is seared off at the level of the orifice. So why should we use bioceramic sealers? Bioceramic sealers are basically composed of tricalcium silicate, dicalcium silicate, colloidal silica, calcium phosphate, monobasic, calcium hydroxide. Some other compositions can be available as well, and of course a thickening agent. It is chemically and dimensionally stable, as there is no shrinkage and expansion when setting. It's biocompatible and osteoconductive. It is not affected by moisture or blood contamination, as moisture actually aids in setting of the bioceramic sealers. And it is an antibacterial, as the pH is above 12 due to the hydration reaction forming calcium hydroxide and the dissociation into calcium and hydroxyl ions from this calcium hydroxide right here. This is the response. This is why the pH is above 12 after the setting. And this is a perfect demonstration of the sealing ability of these bioceramic sealers. As you can see here, using another type of sealers, this obturation would be inadequate and unaccepted. However, when using condensation, hydraulic condensation using bioceramic sealers, the sealer is going to be. This is why we called it a sealer-based obturation, because it is the sealer that's going to seal the space and not the gutta percha. And as you can see here, the isthmus has been filled with bioceramic as well. One question I get a lot is, can we use the sealer on its own without the gutta percha? The answer to this question is absolutely not, because you need that pressure caused by the entrance of the gutta percha inside the canal to cause a hydraulic pushing of the sealer into all the spaces of the canal. So there you go. That's it for today. This was the presentation that spoke about an endodontic obturation. Thank you guys. Thank you everyone who has completed this webinar, and more webinars are going to be available soon. So thank you very much, and have a good one.